All right. Happy Halloween, October 31st. It's a Friday, and the weather's finally turning here in Florida, so it's perfect time of the year to have another great webinar. For those of you who are in the Florida chapter, the NAEMSP Florida chapter, remember that in January, we're having the annual meeting, and the Florida chapter will be meeting. The date for our meeting is going to be Thursday. I'll send out the info for that. And then our dinner is going to be Friday. So the nice thing is we don't have to rush from the meeting to the dinner this year. The dinner will be at 7 p.m. at the Tampa Club. We have filet mignon, we have salmon, we have chicken. We have 3 great sponsors, and we're going all out. So Zoll, Intersurgical, and Trauma Gel are sponsoring quite a big dinner for us. And our keynote speaker is none other than my co-host, Tanner Smita, who will be talking about all things cardiac arrest. So we'll eat, drink, and be merry. So if you're not part of the chapter, we don't charge dues for the Florida chapter. You just got to be a member of the NAEMSP. You could be a doctor, you could be a paramedic, you could be anybody. You can join the company. All right. So with that being said, this joint position statement came out recently in July of 2025. And when I put it out on LinkedIn, it got a pretty big response. On Facebook, it got a pretty big response. And I know Rick Maricle very well. Rick and I have done a lot of work together. And I sent out the email and said, hey, would you mind calling Kate and Lee and anybody else and come on the webinar? And he did. So I'm gonna give it to Rick first, so Rick can introduce the rest of the team. And then I know Kate is the principal investigator and EMS physician, EM physician out of Portland, Maine. But Rick, go ahead and make an introduction of yourself, Kate and Lee, and then we're looking forward to the presentation. Take it away.
All right. Hi, everybody. My name is Rick Maricle. I am here in South Texas, the San Antonio area. I'm the current president for NAVEMS. Full time, I'm with a fire-based EMS system outside of San Antonio, Texas. And I'm really glad to be here with you all today. My background is as a former military working dog handler, trainer, and instructor, and helped with a lot of the initiative for military working dog care by handlers. So I've been on that end of the leash and now currently working, as a clinical educator down here. I'll pass it over to Kate to do a brief intro of herself and then also to Lee.
Hi there, I'm Kate Zimmerman. I am an emergency medicine and EMS physician up at Maine Medical Center in Portland, Maine. I retired my position at the end of June this year as the Associate State Medical Director for Maine EMS, but was involved in writing protocols, the canine protocols for our state. I serve as the medical director of our Portland Police Special Reaction Team, and that's where I started getting involved, I think, with the operational canine aspect of things.
And Lee?
Excellent. And Lee?
Yeah, good morning. I'm a board certified emergency critical care veterinarian. I'm in Auburn, Alabama. Been in the military since '95 in some form or fashion, bomb tech and then a veterinarian. Still serve as a veterinarian in the Army Reserves. Civilian side, I still practice veterinary medicine, paramedic and a SWAT medic and a reserve deputy for our local sheriff's office. And then, yeah, dabbled in being a canine handler myself, but not nearly as experienced as Rick or anybody like that. So yeah, just happy to be here. Thanks.
All right, so we have Texas, Alabama, and Maine. I love how all these groups come together to do great things. So, all right, guys, take it away. Appreciate it.
Awesome, Kate.
All
You
right.
want to get us
Yeah,
started?
sure. So you said I was lead investigator, but I'm really kind of the herder of cats, is how I would describe this project, because this was really Dr. Palmer is going to be it's not going to toot his own horn, but this is really his and Alan Yee's kind of concept, and it just happened that the timing was right, being in the right place at the right time, and willing to do the work that we could pull this off. As you can see, there are 10 authors on this position statement, and there were others that also helped as well. So I need to give folks kind of credit where it's due. But we have realized and recognized through experiences in the military and then on the civilian side the importance of being able to take care of our operational canines, and that there's really a gap that exists where there's a lack of veterinary pre-hospital care. Our veterinarians are typically working in their clinics and emergency rooms. Some may do house calls, but they're not out on scenes with us. They're not out on, search and rescues or tactical scenes to provide care if these canines are injured. But often there are EMS clinicians that are, and EMS clinicians that have the appropriate foundational training that, when translated with appropriate education, can care for these canines. So that's really where this came from. And the National Association of Veterinary EMS and the Veterinary Committee on Trauma partnered with NAEMSP to create this position statement and then the resource document. And I'll just kind of highlight what our recommendations were at the beginning. And then I think we'll walk through with Rick and Lee some slides that kind of highlight those recommendations. So we really feel, all three organizations, that our up canines that are injured or become ill in the line of duty should receive the highest level of resuscitative care as we would our human colleagues, and as close to the point of injury as possible, even without, as I said before, trained licensed veterinary personnel there, because they're often not there. And I think, this stems from our learning of what happens in the military, right? We've translated a lot of military medicine over to civilian medicine, and that is what has happened in the canine field. And so in order to achieve this, we have to collaborate between our EMS, our human, and our veterinary colleagues to create guidelines that are evidence and consensus based. And again, aligned with our EMS clinician scope of practice. And we've posted those on our NAVEMS website. We also have to really try to support the advocacy and for legislation and policy development, right? There are many states, and we'll talk about this a little bit later, that don't have a legislation that would allow an EMS clinician to provide care to an operational canine. And then with that, we just need to increase the awareness that's out there. And I think this is kind of one of those snowballs that is happening in the field right now. And it's really exciting to be part of this as it's gaining traction. So really promoting the awareness and the needs and challenges that are out there that might hinder pre-hospital veterinary care. And so that's what the position statement kind of says. And then our resource document, we go into a little bit more detail in some of the challenges and recommendations that we've seen and that we have. So, Rick, I'll forward to the next slide. You want to talk about just the operational canine in of itself and what that's like?
Yeah, thanks, Kate. I appreciate it. Yeah, operational canines. This is a little bit different term than we're used to, right? We're talking about high threat working dogs that are not just, not just limited to police canines, right? We are also going to discuss search and rescue canines, arson accelerant detection canines. They have a lot of different roles, and they are here to protect our communities. The why, right? As most of us work for government entities, right? What is the why here? Because a vulnerability that affects these assets, right? They protect our community, and when they get hurt or killed or injured in the line of duty, when they're down for a significant period of time, that opens up a vulnerability for drugs to come into our communities, right? For suspects to get away, right, from from their crimes, right? They are a force multiplication of predominantly law enforcement, and I will say a lot of times that they are not just a small tool. They have a huge impact. So if you think about it just very briefly, right? if you work in a small rural area or even a more municipal area, you may only have one canine assigned to your entire region, right, to your entire area to respond. That's the search and rescue canine, looking for your mom or your dad that, wanders off with dementia. That's the drug dog that's searching cars on the traffic stop looking for illicit narcotics that are pouring into your community. That's the canine that's explosive detection that's getting to your kid's school to search for after a bomb threat or some other, phoned in, type threat, to give you that peace of mind. So they're more than just dogs, right? And that's, I look at this as a vulnerability. And there's a lot of different places that they serve, right? Not just our local, municipalities, counties, at the state level, even NGOs, right? And other federal organizations utilize canines, including the military with the Military Working Dog Program. But you'll see a lot of disciplines. Most of these dogs are trained to bite and hold, suspect apprehension. We call that the patrol side of things. You'll have explosive detector canines, narcotic detector canines, and they're trained in certain different types of odors. But it's not only just limited to that, right? There's lithium battery detection canines that work in the jails to prevent electronics, cell phones, and tablets and things like that from making it into, our jails and our prison systems. And we've even had dogs that can locate individuals with infectious disease like COVID-19. So their scent picture is really great. They provide a service that no piece of technology has been able to surpass. And I highly doubt in the next 20 to 30 years, even with AI that's going out there, that we will replace canines in the working environment for a long period of time. But when that vulnerability, happens and they get injured or God forbid they get killed in the line of duty, right? We're looking at several months, maybe even years and tens of thousands of dollars to replace that asset. So, the handler being the first responder, right? EMS being out there working with them, the one who applies the first bandage being the most important. Simple hemorrhage control by EMS, administration of naloxone, cooling from hyperthermia. These simple things make big impacts to save their life, right, and protect that resource. So that's the why. But yeah, if Lee, do you have anything kind of follow up on that on the why and the operational canine?
Lee, you're on mute. Yep.
Yeah, I got that. Yeah, I think the next few slides will kind of reemphasize that as well. But I mean, that's the need. Like, these are definitely force multipliers, like Rick said, in all types of operations, regardless, law enforcement, search and rescue, humanitarian efforts. And so the fact that they're putting themselves on the line every day to, really serve society and protect us from harm's way and everything else. And there really is no first responder for them. I mean, their first responder is their handler. And sadly, look, like 95% of civilian non-military handlers are not trained in first aid enough that can save some of these traumatic injuries for them. And so the first responder then falls to the supporting EMS and human first responders that are on scene with them. There never will be, in my personal experience as a veterinarian, I don't ever foresee there being a structured veterinary EMS organization like there is in human medicine that's been around since the 1960s. Like, we just won't have the funding, the logistical support, or really the numbers to really justify such a system. And so we have a human system in place that can be directly supportive of our mission and help these canines in the line of duty. So yeah.
And I also want to add, just from like personal experience, because I think it's important to tell these the maybe anecdotes, but personally, being on scene and being a tactical EMS clinician. Granted, I'm usually inside the armor, but like if I'm out and I know that these dogs are on the perimeter, it does offer that sense of security. And I will say, like up in Lewiston, we had a canine preacher who was killed in the line of duty this last February, who was there with us that for the duration of that. And you build these bonds with the handlers. and their dogs. And to not be able to provide care if you needed to, I think is really difficult for the emergency medicine or EMS clinician that's there with them too, right? We're all trained to be able to provide care. With that said, and we may talk about this a little bit later, but again, really the safety in working around these dogs, I can't stress enough, particularly the apprehension and patrol dogs, and really understanding their behavior and having adequate training on how to work and move around them and engage the handler is also is key in the education that goes out in these. So, you know, as Rick alluded, you know, the dog that goes out and finds a loved one who has dementia or a child who has wandered off from the home, you know, they fill so many different responsibilities. And, you know, I personally strongly feel that it's our duty to help take care of these partners of ours when we can.
Yeah, and just kind of a last comment on this before we move over. You know, where are we at right now in 2025 with canine handlers and first aid training and their operation of what they're told to do when a canine is injured in the line of duty is what we did prior to 1960s in EMS. Put them in the car and drive fast, right? Diesel boluses, right? Gasoline therapy. That's all they're doing, right? And we know for EMS how that affected our mortality, right, on our highways in the early days of EMS. So, you know, that's the why, right? That's the need, like everybody's saying. But to just kind of put one thing out there, everybody's here, you know, we all teach these courses all over the place, and everybody's so focused on, you know, RSIing these dogs or, you know, intubating them and medications and ACLS. And the answer is that most civilian working dogs just need good old-fashioned BLS care, right? Good old-fashioned BLS care done well, but safety being paramount. Even if the dog's not trained to bite, a dog has teeth, and if he has teeth, he can bite. So, you know, they're going to respond to pain and being manipulated and being stressed with their mouth, right? So even though they're not trained to bite, you still have to be careful.
I'll just add one comment since we're starting off here too. Our goal here is not to replace veterinarians or the veterinary profession. And so again, from a veterinary background, I'm not sure if there's any other veterinary professionals on this call, but you know, one pushback we'll get is from the veterinary side is that, well, we're trying to replace the veterinary professional, and we're really not. We're trying to close a critical gap in veterinary medicine that's not there and probably will never be there. And so the end goal, like Rick said, we're not trying to train EMS to be veterinarians or veterinary technicians and to the advanced scopes of practices beyond what they do for humans. Our goal is to provide that basic point of injury care until they can get to definitive veterinary hospital or a veterinarian somewhere. That's always the end goal. And so I just want to make that, you know, this is not something that we mandate or not something that says everyone shall do. It's a gap we're trying to close with the resources that we currently have.
Well said, Lee.
I was like, I feel we've hammered the need
Yeah, talk about a couple
there.
of things. Yeah. So look at the challenges facing in line of duty, right? These dogs are distinctly operating in these environments, right? And the handler is less than 6 feet away at the end of that leash, right? So handler education is paramount. And anybody who here is thinking about starting an operational canine, you know, treatment program with their EMS agency or working on a TAC med team, my I will challenge you, right? That you should always, and I think Lee and Kay will always agree with me on this, is like if you do not involve the canine handler first in your initial conversations, you're missing the train. Like you're missing the boat here. We are here to support them predominantly, and finding out what your area needs and what your handlers needs are is really, really important, right? So, you know, canine self-aid coming from the handler responder training, that's limited and limited out there. You know, encourage your handlers to get training, right? And if you are, you know, a high-speed clinical educator and you feel like, you know what, we can take some classes and train them, you know, locally, do those things, right? But get training to the handlers. You know, our response times of 7 to 8 minutes on average in the United States is going to be way too long for a life-threatening bleed. We already know this, right? But that handler is there, and they just need some tools and a little bit of training or an adaptation from training that they already know to really do some good things for those dogs. And we're coming in second, right? I hate to say it, we're coming in second due for these types of things. But we will bring tools to the side of at the point of injury to continue that high level of care we provide any other human patient and get them where they need to go to definitive care at a veterinary facility. But it comes with logistical dilemmas. Can I put them on an ambulance? Right? Am I allowed to? Some states you are able to, an EMS clinician is not prohibited from rendering emergency care to an animal, but may not be able to transport them in the ambulance, right? Or they may be able to transport them in the ambulance to a vet clinic, but may not, may not be allowed to practice care. Your state veterinary practice act and your EMS scope of practice and your state laws will something that you'll have to have conversations with to do these things. But have those conversations now because it's not if, it's when. So doing those types of things ahead of time are really going to help you out, provide the best thing for these handlers.
Yeah, I'll add to that real quick and reemphasize that canine handler bond. Like that is a very strong bond. And so like when teaching EMS, like medical interventions is the easy part. You all know how to stop bleeding. You all know how to get an airway. Just making those translational things from a human to a canine, that's the easy part. The harder part is knowing how to work with the canine team. And the canine team is a handler and a canine. So you're not always dealing with one patient, you're dealing with two patients, regardless if both are injured or not. And that canine handler can do so many things for you, provide restraint, provide obedience commands, but can serve as that dog's patient advocate. And so they can keep the dog calm, they can relay information to you, but just the sense of well-being between the two can make the scene, can make the situation so much calmer because they both know each other are there. Also knowing that if a handler's injured, the dog's going to react to that. If the dog's injured, the handler's going to react to that. And so just understanding how strong that bond is and always, as best as possible, I like to relate it to like approaching a parent and a child. We try never to separate them, just if anything else, the psychological aspect of it. And that's the same with the handler and their canine. Like they're going to have a very close bond that if we can, we should try to keep them together throughout the whole continuum of care. And sometimes that's not possible, but that bond is really strong. And so just knowing to keep them two together as much as possible is really key.
I also think that when you're putting on trainings for your EMS clinicians, have the handlers and their dogs come to those trainings too, because it's a time to teach the handler, but it's also we spend the first day of our class really having handlers present and go over the behavior of their dogs and how to work around their dogs and how to work with both of them. And I think that's crucial in any classes that you may be teaching.
Hey, Lee, do you want to go ahead and summarize some statistics?
Yeah, so just to get a perspective of common line of duty injuries and deaths that we see in operational canines, and mainly, unfortunately, the slides that we put together is mainly law enforcement. We have a ton of information from search and rescue as well. But, most of this information we collect off of Memorial Down websites, that are voluntarily put on there. So talking about like the below 100 and law enforcement, we always are within the 20s and 30s of line of duty deaths for canines, but these are just the ones that we have reported. But over the years and decades that we have been collecting this data, commonly the two leading causes of line of duty deaths is going to be heat-related injuries and gunshot wounds. And it just depends upon the year which one predominates. More lately, it's been more gunshot injuries than anything else. If we look at just line of duty injuries, we see a lot of stabbings that occur in the law enforcement canines. From search and rescue, we'll see various things. Typically, search and rescue, we're not dealing with line of duty deaths, just more of line of duty injuries. And from all the different natural disaster, terrorist events over the past decade, starting back from, Oklahoma City bombing, the common things we see there are fatigue, minor cuts and scrapes, stress, diarrhea type things. And so, although not really life-threatening, these are things that will take a canine team out of operation and really jeopardize the mission. And so just knowing and understanding the type of canine disciplines you're working with, and then the kind of injuries that you may commonly see with them.
I think we kind of hit this a little bit in terms of the gap that we're trying to fill between pre-hospital care and getting them to the veterinary clinic. I will say it's really important though for you to be familiar with what your resources are, what kind of clinics are, because not all clinics are hospitals are the same. And really trying to establish those relationships ahead of time. So if I go on a call with my TAC team, we do a medical threat assessment. There's a veterinary part of the threat assessment within there too. So we know if a dog gets injured, where we're going to take them. And if I'm working, sometimes we help our state police. So if I'm outside of the usual jurisdiction that I'm in, we have lists of the various hospitals that are around for our canines, and I may contact them and just verify what resources they have before we go out. So I think that's important in terms of preparedness.
Yeah, and I'll add to that. So the key is knowing where you're going with that canine, and because unfortunately we try to keep them together as a team. We probably all know where our level 1 trauma and level 2 trauma centers are, but for veterinary medicine, that's a little bit different. Although we do have veterinary trauma centers that have kind of the same level of care, we have a lot less than what's in human medicine. And I will tell you that from the veterinary side of things, veterinary medicine has specialized just as much as human medicine. Like, I'm a board certified emergency critical care veterinarian. I don't do cats, I don't do exotics, or I don't do anything like that. There'll be oncologists, there'll be surgeons, there'll be board certified internists. There'll be a lot of veterinary clinics that don't do trauma whatsoever. And so understanding what facilities are in your AO, your area of operation, and where you need to go and what hours operations are is really key for pre-planning, even if you're operating within the same county or region or locale that you're currently working in.
From the EMS perspective, just from the 911 perspective, not the TACMA, because they have the luxury of all that medical threat assessment, right? We can get called to these incidents just because, through dispatch, like, hey, I need an ambulance. My dog just went down with heat and things like that. So have a plan. Not all clinics, nomenclature of these different veterinary facilities are different. A clinic may be a hospital. A hospital may be labeled as a clinic. You just kind of have to know what's around you and know what those resources are. What I've also found out, Lee, and you may tag on this, is like, a more rural veterinarian may be more comfortable doing more invasive procedures than your city, more municipal areas, because they know that they have a lot lack of resources. Do they have blood? Do they have donor dogs at the clinic that can transfuse? How many units of blood do they have? Or do they not have access to blood at all? These are just great things to start with your canine handlers conversations and with the veterinarians in your area.
I will tag on that. I know we're probably a little short on time. Here, you can keep us true to what you need from us. But in the northern part of the state, at least in Maine, Maine's a very large state, is very wooded, and there just aren't as many resources there. And with lessons that we learned from Canine Preacher, he ended up going to a veterinarian that they knew was there. It was one of those more rural vets who tried to do some damage control surgery, but there was no access to blood or transfusions, didn't have the equipment to do a transfusion. So understanding like what your resources are is key. And then we're trying to leverage our emergency critical care vets to maybe do some teaching throughout some of these smaller clinics that may be called upon to care for these dogs and how to do transfusions and things like that. So you truly are trying to help build a system, not just in the pre-hospital realm, but you may be helping facilitate a veterinary care system as well. I think we've touched upon the lack of handlers receiving first aid. So I'll move along. let's talk about, I think if we get into the legality piece of it, I think that's important because I do think that we have folks that are willing to treat an injured canine and we can potentially get them trained. But the legal aspect is a sticking point for folks. So let's talk about that a little bit more. Um, Lee, I'm gonna put you out there because this is your has been your expertise and you've been keeping track of the legislation across the country, if you don't mind.
Yeah, and we talked about some of it already. So we know that there's needs there. We know that there's a gap to be filled. Unfortunately, what has been some of the hindrance from the human EMS side is the authority to do so. And of course, many of us will do so and then, ask for permission later. And there's a lot of gray areas in our veterinary practice acts. There's a clause in most veterinary state practice acts that says that, the owner or the official representative of the owner can legally provide veterinary medicine to their own animals. And so if it's a police canine, the police agency owns the canine. And so anybody that works for the police agency can provide care, without any legal reprisal. But as you know, there's a lot of gray area interpretation there. So in order to close this gap and to make it more amendable for EMS medical directors to authorize and allow their practitioners to provide point of injury care, then, it was necessary to start legislation that legally allows this. And that's what was started. Colorado started this in 2014. They were probably the first state to enact a pre-veterinary care legislation. And then subsequent states have followed thereafter. And I think to date, we have probably 25 states that have now enacted some form of pre-veterinary care legislation, legally authorized an EMS to provide some level of care, point of injury care for an injured operational canine in the line of duty, depending upon the scope of practice of that EMS clinician that's out in the field. And so from there, we've kind of did lessons learned from that. We collect from every state what's worked and what hasn't worked, what we should change. And so in every component, there is, this is not a shall respond and provide and have a duty to act for injured canines. It's more of a you can if you have the resources and time. Going off the premise that human patients always take priority in the hierarchy of life and hierarchy of care. And so as long as you have the time, the resources, the personnel to provide care to the injured canine after you've taken care of all human patients, then you're good to go as long as your EMS director is good with you and your state legally authorizes you to do so. Every state's a little bit different. Some are a little bit more restrictive. Florida, last time I checked, you're authorized to provide a level of care to injured canines and to transport them. Some states only allow transport, and that was kind of just a stepping stone to at least get legislation enacted. Some states will state exactly what you can, like specific interventions that you can do as you provide care to these injured canines, and some are just very open. One thing we try to emphasize, like we're just advocate for it. We can't enforce anybody or any state to say what they have to put in their legislation. But the one thing we try to get into the legislation is that there has to be some sort of training component to it. Because just because you're legally allowed to do something doesn't mean you should if you don't know what you're doing, and kind of the do no harm thing. And so, like I said before, although there's a lot from human medicine that's directly translational to that of point of injury basic care for a canine, there are some differences. And so just knowing what's appropriate, what's not appropriate, making sure that we're doing anything for malfeasance or anything like that, then there has to be some level of training. Unfortunately, Massachusetts they passed their NERO's law back in 2022. Really good. It was really well written legislation until, unfortunately, until the final passing of it, they put in a lot of words that said, shall do this, shall do that. And that shall just made it very restrictive of what can and cannot be done for those EMS clinicians. And so those are just things we try to avoid. This was just a list, this probably needs to be updated a little bit. I'm in Alabama, and the fact that Alabama actually passed some sort of legislation like this is, to me, a miracle. So if Alabama can do it, then any state should be able to do it. But I'm not originally from Alabama, so but yeah, this probably needs to be updated, but that's the goal. We're just trying to take out that gray zone and make it more black and white, that EMS can legally provide pre-hospital care to the canines that are injured. And so with that, we had our two different initiatives to help also close the gap in pre-hospital care. There's the Canine Tactile Emergency Casualty Care Group. That's something to talk about too much today. That was formed back in 2010, if I remember correctly, and that was formed under the purview of the Committee of Tactile Emergency Casualty Care, the Human Committee. And so that has the same premise, to provide point of injury guidelines for TAC medics, EMS, that are providing care to injured operational canines under a high threat situation. That's not just law enforcement. It could be search and rescue, could be, urban search and rescue canines are operating in a structural collapse or anything like that. And then there's NAVEMS, which is what we've already been talking about. Take it back over to you, Rick.
Yeah, so with NAVEMS, we are really as an organization, we are helping to bring the communities together, right? We're looking to take over anything of that. We're bringing VetCOT and bringing NAEMSP and everything together to advocate for this and provide professional ethical standards, guidelines, and best practices. More of a best practice organization to close this gap, like Lee has said, and really in that regard, right? We will be and have been generating some of these discussions and some of this documentation. I will, if y'all want to check it out, check out our website. We're still building things. We're still new in the world, so we're building things out. Our Facebook page and our website. But there's a lot of little tidbits and resources, papers. Kate helped organize, heard the dogs of sort, heard the cats of sorts to help get our scope of practice guidelines done. These are recommendations, right? It's not a shall be of any sort, right? These are recommendations on how we should translate current EMS scope of practice to veterinary scope of practice. So that scope of practice document is up there. Our paper is available out there to look at, and we continue to, build out core competencies, core content, and along with now providing a home for canine TECC as well on the tactical aspect. So I will let Lee kind of take back over to close this out, at least with the slideshow. I'll just talk about the PVFR course and what we're looking to do with that over the next little bit of time.
Yeah, so like the premise going off of, there has to be some training component. And so similar to what you have in like NAEMT with PHTLS programs. And so we wanted to get some sort of curriculum and training standards. This is part of our vision of educational standards that all states, regions can use as a template to develop their own canine pre-hospital care programs and protocols, is to develop our pre-hospital veterinary first responder course. And so it's something that we've piloted for the last 3 years at certain locations, and are hoping to get it expanded out further and to get training out. Again, the goal is to provide some level of basic training, but also provide a template and resources that states and regions can use to develop their own programs and continue on the training. And one of our 2 piloted programs is just a basic provider course. And then we also have kind of like an instructor train the trainer course. And so kind of just following off the way the humans programs go, you take the provider course and then you attend the instructor course. And ideally, we're not there yet, would be that, you see one, you do one, and then you can actually be the instructor and then actually train it to your folks that are in your region and stuff. And so that's the goal of that course right now.
And I know everybody's asking this question right now. It's like, well, how do I take these courses and things like that? We are still just kind of beta testing these currently. So just have a little bit of patience with us to kind of wrap these up and get those out there and advertise those a little bit more. But there's been a lot of work done over the past several years to bring this course out to everybody. Because I know, Lee, we're about to get asked that question blown up, like, where's the next class? When can I take this? So just want to address that real quick.
The next couple slides, we've already discussed about the legality of things and the importance of establishing our relationships and getting proper training. So that kind of brings us to our last slide, which really just kind of shows how NAVEMS and VetCOT, along with NAEMSP, are really trying to help bridge that gap from point of injury care to definitive care. So I think at this point, we can address some questions. That would be wonderful.
Awesome. I learned so much. I am a dog owner, but I have zero experience in the field with canines. I know we have a lot of people on the call who do, however, and I know Chief Bill McGrath, you are on the call. I know that you're very involved. I'd love to hear your thoughts and comments on this. Bill, I'm calling you out. Where are you? Maybe Bill is not there. Well, the comments I want to make is that you guys have made really a lot of kind of forward movement on this. And he says, you know why? Sorry, that's me. I have to let everybody unmute. I do that for the spam reason. Hold on a second. Okay. Bill, try now.
Yep. Can you hear me?
Yeah, I got you now. Go ahead.
Yeah, no, appreciate it. No, great information. Thank you guys for what you're doing. I mean, what we're doing, obviously we don't have apprehension and bite dogs. We have a large therapy dog team. So it is integrated quite often with police, fire. And we're once a year, we have 18 handlers within our organization, and we're doing once a year canine care, including CPR and first aid, but a large majority of our group are medics. So we do go through intubation and decompression and IV access and all of those types of things. But our air rescue, just for your knowledge, Doc, is now that we have a hoisting helicopter, we're talking about, and we just had a training the other day of hoisting, whether they be apprehension dogs, bite dogs, therapy dogs that happen to be injured, what's the best way to hoist them. So they had some carriers that they have. So they were putting some dogs in it just to see if they would fit. Obviously, we weren't hoisting awake and alert dogs, but that conversation is taking place, which is leaps and bounds of where we were years ago to where we are now, that they're considered as just part of the team, which is great. So the advanced care is there, but I think you guys all made a great point. A large majority are police operators, and when they're in our classes and we're talking about intubation and decompression, I'm sitting there going, they're never going to do this. It's great that they may have it in their kit, but especially if they're the handler, that's like almost treating your own kid, which would be very, very difficult. So, but it's still, again, leaps and bounds where we are. So kudos to you guys for what you're doing.
Thank you. Thanks, Chief.
Well, thanks.
Before I pass it over to my, go ahead, Rick. You want to make a comment?
No, just real quick, Chief, I dropped some stuff in the chat for our board email and then just my personal one as well. We are looking at some best practices for air medical transport. We know that this is a hot topic, and if there's things you guys want to help collaborate on, we'd love to get those best practices and work through that project. So I just put my contact information.
Great, thank you.
Excellent. Before I pass it over to Tanner, my quick question is, I see that you have a course laid out. Question number one is, I didn't have a second to add up how long that course is going to be, number one. And then number two, who do you envision takes that course? So for example, Palm Beach County Fire Rescue, we have over 1,500 people. Who takes the course that you've created in a department? Is it everybody? Is it some people? And how frequent do you see that training?
I mean, ideally, the vision would be that everybody who would respond to and be involved in responding to an injured canine would take at least the provider course. The provider course, again, we're kind of beta testing, we have various modules that can be, depending upon the skill level, the scope of practice, could be 4 hours, could be 8 hours. If we're looking, if you have your training instructors, then they would be more inclined to take the train the trainer. And so that way you have your trainers involved, just like you would for any other class, that a handful that would continue the annual, not annual, or again, we're looking at trying to mirror it off what human training certifications are, whether it's every 2 years, every 4 years, and then get recertified in that time period. So you can have the local trainers provide that course. We're also looking at similarly, not just being in-person courses, but being kind of a hybrid where you do a certain portion online, and then there would be like a skills practical day, and whether that's just a 4 hours of skills practice or 8 hours of one day where you get all the advanced skills. And again, just depend upon the levels from either basic to advanced.
I will
Okay,
say,
and no, go ahead, Kate.
I was supposed to say in Maine, so we were the beta for, I think, more of the advanced class. Lee, you were involved with this before I got involved. But we have a 2.5 day course that we do. So it is about a 20-hour course with a mix of students from handlers all the way through paramedics, some veterinarians, vet techs, docs will take it. And we've also created a basic course that we can get done in an 8 hour. But that's really kind of crunching in a lot of the information.
Interesting. Yeah, because as many of you know, especially if you're in a fire-based system, the calendar is very, very thin, right? It's very hard for us to get even any of the regular training in. So definitely keeping it to as short as possible would be important. So thanks for that. Let me bring in my co-host Tanner Smita. Go ahead, Tanner.
Yeah, first of all, I'd just like to say, thank you for all the effort that you put into this and putting together the position statement. I enjoyed reading it. I was delighted to see that, I've done a number of studies with the National Trauma Data Bank that collects data from human trauma centers. There's a dog one out there too, or a veterinary trauma registry as well to pull data from. So I thought that was awesome. In terms of questions I have for you, so first of all, is there some centralized resource that we can go to, a map or some registry where we can say, here are the canine trauma centers, the veterinary hospitals that are near me or are in my state, and what level of care do they provide? Is there some centralized way to track that information? Or do we have to go and call local veterinary clinics ourselves to try to find out who is where and what they can provide? So that's my first question. Second of all, I really liked in the position statement how you highlighted the epidemiology of kind of what injuries are actually leading to the deaths of these canines. And I think that especially with the heat related deaths, the environmental emergencies, that's we can intervene there very easily, right? We have plenty of EMS agencies that are doing cold water immersion protocols on scene. I think simply saying, yeah, we can extend that to dogs. We should be doing that on scene if there's a canine that's experiencing one of these emergencies. I think that's very impactful, and anybody can do it, ALS, BLS. Final question. So do we have any data describing the preventability of some of these canine deaths? We talk about, some of these are related to heat. Some of them are related to gunshot wounds, stab wounds. What proportion of these are like dogs with exposed brain matter where no pre-hospital interventions would actually have worked to save them? What proportion of those heat-related deaths were, a dog that was found in a car in asystole, right? Is there any data out there that addresses kind of what proportion of these patients the animals could have been saved with intervention?
So I'll tackle the first question initially. So as for a database and registry for hospitals, so the Veterinary Committee of Trauma, they have developed, again, levels of veterinary trauma centers located throughout the country. Unfortunately, like I said, they've started, I can't remember, a few years ago. We may have less than 30 veterinary trauma centers scattered throughout the country. Now that doesn't mean, so there is if you go to their website, they do have a map of the locations of those veterinary trauma centers. However, that does not mean that there are not anything within your region or your area that there's a hospital or university that does not have the same resources and the extent that you can use as a level 1 trauma center. They're just not currently certified as one. Unfortunately, we don't have a registry saying where all the local hospitals and clinics are for each state. So kind of like what Maine has done and what the Michigan State Police has done as well, is they've identified hospitals within each region that they operate in, whether it's counties, parishes, whatever, that they know will be open 24/7 and will have the resources to go to. So on that end, yeah, it's a little bit on you to find out. And that's kind of why we go back to establishing that rapport with that veterinary facility, because some facilities, they only do vaccines. Some facilities, they're only open till 5. And so just establishing that rapport with them. So again, some of it, the onus is on you for doing that currently. As for heat-related injuries,
Lee,
sorry.
can I intervene? Sorry, Lucy is making an appearance. I told you, Peter,
All
that she would
right.
jump in. I know the Maine, our Veterinary Medical Association website also has lists of veterinary and after-hour clinics. New Hampshire's does. So check your Veterinary Medical Association website as well. I know that ours, we just got 2 new hospitals, so we'll be updating ours, which is exciting because those are in the northern part of the state where we're really our resources were short.
But it sounds like every agency needs to determine what their local resources are.
Yes.
Right. Okay.
Yeah.
Right. Okay, Lee, go ahead.
I wasn't sure about what the second question was actually. What there was the second question. The third part of that, as for do we have data on which of these line of duty deaths or deaths are actually preventable based on the mechanisms of action and injury patterns? Great question. Like, we have a trauma registry through the Veterinary Committee of Trauma, and it's got over 40,000 cases now. The data that's collected in there is not really specific to injury patterns per se, or mechanisms of injuries that would help us say, well, how many of these could have been preventable? What I will tell you is that how we teach it is heat-related injuries being one of the #1 leading causes of death is truly a preventable cause of death. There is really no reason, like you said, we have the resources, we have the knowledge. There's really no reason that we should have canines dying from heat-related deaths. And unfortunately, a lot of that comes down to handler education. And it's not handler education, handler awareness. And it's not because the handlers don't want the education. It's not because they're just being negligent in what they know. It's because they just don't have the opportunity to receive it, whether it's time, whether it's funding. They don't get any of this in their handler training schools. And so really, if we could have better, in fact, I just did a 40-page lit review on heat-related illnesses in canines. And the #1 thing for prevention was education and awareness of people involved in the canine program, and particularly the handlers. So
Thank you.
Perfect. All right, excellent. All right, Lou Steinberg, I see you raise your hand, and you have your dog sleeping behind you, I think. So you know.
No, he escaped because you were talking about epinephrine studies, and he doesn't want to hear it anymore. For any of the presenters, so most rescue units, ambulances don't have canine masks. So short of intubating, I know there's a V-gel for dogs. Do any of the human supraglottic airways work on dogs? Or do we need to just intubate if you don't have the proper equipment?
yeah, no, we don't have none of them that there's only one study that looked at using the combi tube that I don't think anybody really carries anymore. But we do have extraglottic airways for canines, but they're veterinary specific. We have not done any tests to evaluate any of the human King LTs, the eye gels, or anything like that. And so at this point in time, it's not something we recommend because we have no clue if they would actually work. I believe they would work, but again, we just don't have data. So currently recommended and plus the other fact is that if you have the training and you have the scope of practice, that directly intubating a dog is 10 times easier than a person. And so there really is no need for them. And that's one of the reasons we don't get funded to test some of these things.
Okay, thanks.
All right, excellent. So Tanner, you said the eye gel works on a pig. I'm not sure, is that the same anatomy there or not?
So in Jim Menegazzi's pig lab. They done a few studies looking at like the safe BVM and the butterfly BVM that are automatically pressure and volume limiting. And as part of that series of experiments, they had, you know, kind of I believe it was actually a canine BVM that they used for some of the experiments. And then they used, I think it was a size 5 eye gel, and just tried it with the ventilator on a few animals, and it formed a seal. And they were able to get good tidal volumes using their, you know, standard kind of anesthesia circuit.
So I will add to that, and that you are correct. Yes. And like that's what I said, my suspicion is, and it's more of a suspicion. I just so much detail I can go into, is that they will work. It's just we don't have any definitive data that's published that's saying they will work. And so it's not a recommendation we can make at this time.
Excellent.
And the way to look at this too is that for the EMS clinicians here, we're so focused on peer-reviewed evidence-based, you know, randomized controlled trials and sources and things like that. You know, veterinary medicine hasn't had a need for supraglottics. They intubate them, right? It's either they self-maintain their airway, they intubate them. So there's never been an impetus on the veterinary side to explore these extra glottic devices. So that's our predominant wheelhouse pre-hospital as a first line airway for cardiac arrest and all those other things. So this is where that mashing of communities gets together, and we're having these great conversations. But you know, I will say that, you know, veterinary literature moves, you know, I'll say, Lee, you probably agree with me, moves pretty slow. It's kind of like what we see with pediatric literature, right? It kind of moves a little bit on the slower side of things. But not due to you know, anybody's fault. It just comes down to funding and just those types of things that are out there. But yeah, that's why I think.
Yeah, great comment. I'm going to bring in Ari Miller. Ari, are you with Tampa General? You made some comments. Introduce yourself, and sounds like you have some experience in this realm.
I
Love to
do.
hear your thoughts.
Thank you. Let me see if I can even turn my camera on here, potentially. Maybe, maybe not. So anyway, good morning, everyone. Yes, my name is Ari Miller. I'm our program director here at AeroMed, which is our TGH helicopter EMS program. And we actually established our guidelines and our training both internally and externally on canine care and transport. We actually went back and looked at some dates, and it goes all the way back to 2022. So we were blessed enough to actually have our foundation provide us 2 of the canine simulators that are out there on the market, which really have met the need for both our internal and external training. So when we partner with both our EMS and our law enforcement agents partners, specifically those canine handlers, we have, we'll say, kind of 2 different training programs that we offer. Like we offer the advanced program, of course, for our team, and then for our fire rescue, and then focus more on those basic maneuvers and skills as well then for our canine handlers, like what they're going to have on them and accessible to them in order to be able to render care either solely or you know, while they're waiting on, you know, medical providers to get there to provide advanced care. When we talk about the vet centers, we did a lot of groundwork in identifying what those centers were. And I'm going to give kudos to 2 others that are here on the meeting with us, Donnie Richardson and James Houston, both with our program. And they've really helped assist us in getting this up and off the ground. But we went to all of the vet centers that the canine handlers had identified that they get their care from, and then vetted, no pun intended, like which of those facilities actually had 24/7 surgical capability. They had blood resources, they had anti-venom. And then we scouted out areas that for us, you know, as an air medical transport, that we would actually be able to utilize as an LZ. And then we built that all into our CAD system also. So intaking a canine transport request for us is really essentially the same as any transport request. We just identify by the requester that this is for a canine, and then based off of the scene location, we pull it up in our CAD to identify where we're transporting to.
Oh, Impressive. All right, I'm gonna send you an email. We should stay in contact, and it's something for the state to continue to learn more about. Appreciate that. And then
Absolutely.
Lee, you said acquiring a canine oxygen mask that attaches to BVM can provide effective ventilations. So that's
Yeah, so your BVM has the face mask, so it's not going to fit a canine, but they do make canine specific oxygen face masks, and so acquiring that has the same connection that attaches right to your BVM. You can has an adapter attaches to oxygen lines and hoses, and so that's something we typically recommend. It has a diaphragm on it, so you put it on, it creates a pretty good seal on the canine snout, and so therefore having at least that on board will at least provide, as long as you're not dealing with airway obstruction, then at least provide effective ventilations.
excellent. All right, well, we've reached the top of the hour. This clearly was a topic that needed a lot more than 30 minutes, probably a lot more than 60 minutes. We always like to give our presenters the last word. So Kate, I'll start with you, go to Rick, and then finish with Lee. Give us a take-home point. Some of us have some experience, people like me have none. Give us some takeaways that we can consider through the rest of this year and into next year for our agencies.
Collaboration. So really collaborating with your veterinary clinicians who are the experts in this, as well as the handlers. I can't stress the handlers and the handler bond enough.
Great point, Rick.
Yeah, planning, right? It's not if, it's when. And if not you, then who, right? So I will say that planning, again, it goes back to that collaboration piece. You may not have to have a full, canine transport program and protocols and have to go through a lot of this, to be capable to do the right thing ethically and safely at the right time. But having those conversations and collaboration, I get asked a lot of time about equipment and things like that. The same things you have on your ambulance, minus some very few select things like the Surgery Vet mask. So planning.
Gotcha, great. And then Lee, go ahead, finish this off.
Yeah, I'm with both of them. I mean, the collaboration piece is key. I mean, there's so many things that EMS can learn from the veterinary counterparts, but there's a lot of things that veterinarians can learn from EMS. Like we don't get pre-hospital training in our curriculum or our professional degrees, and so learning how they can translate their knowledge to you as EMS providers, what resources you have, what knowledge you have will help them so much. And then going back to that canine handler bond, like that just, you can't emphasize that much, and just establishing a rapport with teams that you work with so you can all work together and train together. Yeah.
Wow. Oh, this is amazing. We had a lot of people today, a lot of people online. I'm sure a lot of people watch us on YouTube. You guys are starting something special, and clearly there's a lot of people who want to get involved. So on behalf of myself and Tanner and the entire Florida chapter, thank you all so much for joining. This will be on YouTube hopefully later today. And we hope to see more of you all on more webinars, more podcasts to get the word out for all that you do for our four-legged friends. Thank you guys so much, and happy Halloween. Take care, everybody. Be safe, and have a great weekend. Thank you, guys.